Rahul Chobe from Ortho TV. So today's live webinar series on spinal cord injury, its overview of its demographics, management and rehabilitation. Today we have a speaker, Dr. Pramod Bilare and Dr. Sonal Shahas. I'm handing over the session to Dr. Pramod Bilare to introduce the panelist and the one more speaker. Over to you, Dr. Pramod Bilare.
So, good evening all. So, today's topic is basically a spinal rehabilitation. A very important topic where we'll be discussing about the overview on demographics. So, what are the different strategies we plan in the management of spinal cord injury, and also the management part of it, and including the rehabilitation. So, as suggested, it's a very important topic, and to help us with the topic, we have Dr. Vishal Chaudhary, who is a spine consultant HOD, head of the department at Noble Hospital, Pune itself. He's a very well-known figure in orthopedic spine as well as pelvic trauma. He has worked in multiple institutes, including KEM, Nair, Cooper Hospital in Bombay, also in Nanavati, and presently is head of the department in Noble Hospital, Adavsar. We have the second panelist with us, Dr. Radha Bhattad, who is actually the head of the department in Neurophysiotherapy department in Sancheti Hospital itself. I'm delighted to welcome Dr. Sonal Shah, who is the next speaker, who will be primarily going to talk on the management part of it, the rehab part of the talk, which is actually a very important talk as far as the webinar is concerned. So, with this introduction, I would like to go ahead on the topic that today's webinar is. So we can see the statistics. So why we have choose this topic to talk about. So to see a simple statistic where the world stands as far as the spinal cord injury is concerned. So as high as 250,000 to 5 lakh people suffer from spinal cord injury. And this is a WHO statistics, and it is all over the world every year. Now this is a huge number. Whenever you talk about complications or morbidity or mortality related to any disease per se. So people with spinal cord injury are 2 to 5 times more likely to die prematurely than people without a spinal cord injury. And obviously the worse rates or the worse survival rates in low and middle income countries, and India unfortunately lies in low and middle income countries, and the mortality is probably more than what has been stated on a world map. So to just give you a brief account, so this is what the entire picture is, and this is statistics from the US data, where the most common cause of spinal cord injury is actually a motor vehicular accident, which is as high as 38.4%, and then comes next the falls. The most likely age affected is actually 29 to 42. Now this is a very important age group. This is actually the age running the country. So if this age is affected so much, we know that the survival for these patients are next 30 or 40 years, which is the usual life expectancy of any patient. And they are going to live for another 30, 40 years. And if you don't do anything to the spinal cord injury per se, the damage has occurred at the time of the injury, and the subsequent damages occurs when you are treating them at the hospital or subsequently. So this is a huge figure as far as statistics are concerned. The demographic trend to talk about. So the males are obviously at a higher risk, since in most of the countries, including India, the males are the ones who are actually outside. They are the ones who are involved in vehicular accidents. Those are the ones who are actually doing high-end jobs and high riskier job, where the chances of having a spinal injuries are very high. The females are most at a risk when they are at their adolescence age, when they are very active, or at the older age when the osteoporosis has already set in. That time, still there is a high chance with a trivial trauma they can have a spinal cord injury. So as far as the statistics statistics are concerned between the male is to female ratio, the ratio is as good as 2:1, where there is more preponderance of the male sex. So what do you want to talk about? So it not only is an injury per se what we are going to talk about, but the complications involved in managing or complications which leads after the spinal cord injury patients, and the complication can go simply from a bed source to as high as the death of the patients. Now taking some patient's life after the patient has injured himself is also a very possibility whenever you are talking about a spinal cord injury patient. So this is a very important data from Russia, where they had actually found out the complication mortality after an acute traumatic spinal cord injury in a St. Petersburg, Russia institutes. So where they have found out that these are the different list of complications a spinal cord injury patient can land up with. It can be thromboembolism, DVT, it can be a post-operative infection, it can be respiratory complications like pneumonia, pressure or a bed sore ulcer, and a urinary tract infection because of a long-standing indwelling catheter. So there are different complications being treated. There have been seen that the Asia score, where the Asia A being the severest of the deficit, where there is no power sensory below that level, as well as the Asia E, where there is slight power or a good power rather at a level below the injury, where we can see that Asia, obviously Asia, the more the gross deficit is, the chances of complications are also higher. Whereas the better neurology is, the complications are relatively lesser. Also, it depends on what level the injury has occurred. The cervical injury will lead to the patient being a quadriplegic compared to a thoracic or a thoracolumbar, in which the patient will be either a paraplegic or a paraparetic. So in both the cases, the if you see the cervical will have more morbidity or more complication and more mortality seen compared to a lumbar or a sacral fractures. Also, with a concomitant traumatic brain injury. So, a concomitant traumatic brain injury obviously will add on to the morbidity as well as the mortality of the patient. This data is actually cross-sectional data from the entire Europe, and it had actually pulled analysis of 22 countries, and where they had shown the more the age, the more chances of morbidity and mortality are. So the higher age group will have more chances of death related to a spinal cord injury patients. So talking about the types, when you talk about spinal cord injury, you always want to classify them as far as if the patient is tetraplegic or quadriplegic, is it the patient having paraplegic or paraparesis. So depending on what level you have injury, you can have different types. You can have a quadriplegia or quadriparesis. You can have uh, paraplegia or both the lower limbs involved, and or paraparesis when the weakness is not zero or the power is not zero. You can have roughly a complete vis-a-vis an incomplete injury, where the complete injury suggests that the power, sensations, bowel bladder involvement below that level is completely gone. So that is something called as complete or a dense paraplegia or a quadriplegia, compared to a incomplete cord injury where there is a slight power, sensory, or bowel bladder involvement, some power, some sensations, or bowel bladder is spared below the level of injury. In those cases, it is an incomplete cord injury. We need to classify either it's incomplete or an incomplete. That helps us to prognosticate whether your intervention is going to help the patient, in what way you can expect the rehabilitation protocol. A complete paraplegia vis-a-vis an incomplete paraplegia, where the chances of recovery in an incomplete paraplegia is slightly higher compared to a complete paraplegia. So here, always and always, prevention is cure. So the prevention is at multiple level. It's not only, first of all, no one should land up with these accidents, but if at all someone has landed up with an accident, you should make sure you prevent the secondary injury. Now this second prevention ladder is at the prevention of secondary injury. So what is this primary and secondary injury? So when you talk about the pathophysiology, the primary injury has occurred when the patient has sustained the trauma. So there is a contusion, there is shear forces acting on the cord, there is compression, laceration, stretch, leading to the primary cord injury. Then what you need to be very careful, or rather be very vigilant, is not to cause the secondary injury. So something like an hypotension because of because of the blood loss, or if the injury is at the level of T6 to T12, then the patient can have a neurogenic hypotension, neurogenic shock. That is the time you need to build up the BP. You need to build up the blood pressure to above 90 mean arterial pressure. Also, to prevent the secondary cellular which can occur because of the free radical release, because of the hypotension, because of the free radical and the secondary factors which are released at the time, at the incident of the trauma, where there is a lot of influx of the free radicals leading to mitochondrial damage, cell swelling, ultimately leading to irreversible damage to the cord. Also, you need to take care of the transfer. You need to take care of the secondary injury which is occurring during the transfer. So when you talk about the prevention of the secondary injuries, not at the hospital, but you should talk at the time of the transfer when the injury has occurred, and from there the patient is referred to the hospital. You can have multiple injuries at the site when the patient is being transferred. So this is a classical example where the patient here, this is a high-end player where he has developed an injury and he's been taken away. You can see so many people are carrying him with a patient being strapped to the spinal cord where he is absolutely immobilized. So this is what is very important. Many a times the patient has sustained an injury, patient has a very subtle injury to the cord where the power in the legs are present, kind of an incomplete cord injury. And just because the patient was transferred to the hospital in an inadequate way, the patient has suffered a complete cord injury, and which might be irreversible. So the secondary injury starts at the time of transfer. This will not only decrease the amount of mortality associated with the injury, but also the morbidity with the patient will land on later on. So which is an important concept. So this the same concept has been applied in the ATS, that is an advanced trauma life support. I am a speaker as well as a faculty for the ATLS, where we brief all the candidates and the delegates about the importance of cervical spine protection. So now cervical spine protection has given such a high rating there, where it starts as the first step. Along with the airway and management, the cervical spine protection is given. Now, you know, if the cervical spine is not protected, the cord injury, especially in the cervical and a high cervical trauma, will lead to an ascending edema, affect the breathing, and ultimately the patient will die. Most of the patients who had suffered a high velocity injury will be unconscious. If you don't protect their cervical spine and leave them dangling, you know that the secondary injury to the cervical cord has occurred now, and the cord has swollen up and edematous and leading to breathing problem, and ultimately patient will die. So importance in ATLS concept we teach is to definitely protect the cervical spine. The next step in an ATLS concept comes when the patient is being monitored for the D, that is disability. You check for the motors, you check for the sensory examination. You have to take care of the cervical spine before. Now you're actually concerned about the thoracolumbar along with the weakness which has led because of the cervical spine trauma. So there is the second time you check for the power, sensory reflexes, sphincter control, how is the sphincter control, and then you examine the spine from the back. But in terms of the sequences, D comes slightly lower, and usually there won't be much trauma or much morbidity or mortality associated because you are having thoracolumbar trauma. The important thing when you are seeing the patient in the casualty with any spinal cord injury patient is cervical. When you talk about cervical spine, you think about Nexus Criteria or a Canadian C rule. Both are the ways where you want to rule out whether the patient is having a cervical trauma or not. The simpler one is a Nexus Criteria, where a Nexus stands for National Emergency X-ray Utilization Study. Now here they have given certain criteria where N stands for neurodeficit, E is ethyl alcohol or intoxication, X is an extreme distraction injury, U is unable to provide history, S is spinal tenderness. If any of the answer is yes, then you know for sure that the patient is having cervical or thoracolumbar trauma. Mainly this Nexus criteria is primarily based for the cervical spine. So you know that the patient is having cervical spine injury whenever the answer is yes, we need to protect the patient. If the patient is unconscious, we are not able to elicit the history, neither judge the power in the legs, consider the patient is having a cervical spine injury unless and until proven otherwise. So very important factor whenever you are managing the patient of a cervical spine trauma in a casualty. The second important one is a Canadian C rule, where you see the age, you see the mechanism of fall, whether it is from more than 1 meter, whether there was any axial loading, whether it was a motor vehicular accident with ejection, whether there was a bicycle collision. So modes of injuries considered, the paresthesias in all the limbs are considered. Also, you check for rotation at the neck. If you can rotate the neck 45 degree from left to right, you can. If most of the answers are yes, you don't have age more. That is, age is more than 65 with the dangerous mechanism, with paresthesia, with rotation restriction of 45 degree on either side. You know that the patient is having injury, and the patient mandates imaging. Patient requires further imaging. If the imaging is not possible at the same time, you should not discard the immobilization of the cervical spine you have done just because you have not able to elicit the STN examination. So if you see the Zoe 2012 paper, which is a 15 studies, they had found out the Canadian C rule is slightly better in terms of sensitivity and specificity is concerned, and Nexus was relatively had a less specificity but a higher sensitivity and a comparable sensitivity. The Canadian C rule is slightly more better compared to Nexus criteria. When you are done with all the Nexus criteria, whenever you think about the cervical spine injury safe, now you go for the Asia scoring. Now the Asia scoring is kind of an adaptation from the Frankel grading, which tells you the amount of spinal cord injury the patient is having, to quantify the amount of patient's deficit the patient is having, where you check the motors in the key muscles. You also check the sensory, where you check for the light touch and the pinprick, and the muscles you check it from the C5 to T1 in an upper limb, whereas in the lower limb it is from the L2 to S1. Along with that, you check for the voluntary anal contraction. You also check for, you do the mapping of the power in also the sensory power in the upper and the lower limb. You see whether what zones of sensory is preserved. You also classify based on this scoring whether patient is having a complete or an incomplete injury. So if you have to classify, you know that A, that I had discussed earlier, that A is complete injury. So there is no power sensory or sensation preserved in the sacral or the caudal most segments at the S4 and S5. You know that the patient is having an incomplete or a dense weakness compared to E, where the patient is absolutely normal. To document the sensory motor and neurological level involvement, the Asia score will help you out in all those things. So depending on that, you label it the sensory level, what is the sensory level, what is the motor level, and what is the neurological level. Very important thing, there is a stepwise algorithm how you need to follow for the Asia score. Coming to the principles, how do you manage such spinal cord injury patient? Now, the patients you have already ruled out the cervical spine injury, or the, you know what kind of injury the patient is having, what level of Asia classification the patient is having. Now you want to deal with the patient in terms of managing the patient. Then you know that the management principles are not straightforward. It is never a one-on-one discussion with the patient. It's a multidisciplinary approach where you have to take into consideration different opinions, right, from the medicine people, the psychologists, the dietary advice, the nursing, what you are going to give, wound care specialists, rehabilitation therapists, also the biomedical engineering required for all the equipments and the basic needs required for mobilization of the patient. So it is not always straightforward. It is always a multidisciplinary approach. When you talk about the injury, the first injury, the primary injury has occurred at the time of the injury event. When you see the patient later on, it is always immediate, early acute, or subacute, which occurs at the seconds, minutes, hours, or weeks after the injury. And here is the role of the neuroprotective agents. Now, there are different neuroprotective agents being discussed. As good as methylprednisolone, succinate is the most common drug which has been invoked since the last 3 or 4 decades. You have already, there are different papers available on this. Methylprednisolone is a steroid of choice because it has a better cell permeability and its concentration at the cellular level and at the barrier level is much higher compared to the higher steroids. The other drugs which are used are naloxone, you have riluzole, which is coming up, and different papers and promising papers are being published based on the results. There are others like erythropoietin, there is vitamin D, there are colonies stimulating factor agents. So what they are basically doing is to prevent the secondary type of injury. So the most or the vital questions about the last 2 decades have been the role of steroids. Does the steroid help us? Does it help us in management of the patients? So here I want to take an opinion. So we have Dr. Vishal. So Dr. Vishal, in your practice, you have seen the NASIS studies being published right from 84 to 90 to 97 by Bracken et al. Then you had so many controversial papers stating the benefits of steroids or some stating against the steroids. What is your management whenever you think about a spinal cord injury patient coming to your hospital or casualty? Do you give steroids or you still withhold the steroids?
Yeah, actually, as you told just now, there are a number of neuroprotective agents which we can give. But methylprednisolone or steroid is the one agent which is most vastly studied, and it is many people are using it since last 3 to 4 decades. In my experience, also I used to do the methylprednisolone, but the dose which is recommended is very high. We cannot inject or bombard the patient with a very high dose. But I used to give solumetrol 1 gram after the time of injury, and generally don't give any infusion pumps of the steroids. And if needed, I repeat on the second or third day or later on. But
Okay. So any particular thing you have seen the complications of steroid being mentioned right from the decreased immunity causing sepsis to
exactly,
pneumonias and
uh,
different complications?
right. But if the patient is already immunocompromised, having the lot of comorbidities, if the age is more than 65 or 70, and having a very high diabetic, very high sugar at the time of the admission, then it's definitely the steroids is very cautiously administered. And even if it is, we don't give the steroids, it is much beneficial for the patient to just to reduce the later on complication in terms of infection and all. But as we observe, most of the patients with spinal cord injury as are below the age of 50 years or 60 years, and they are in the middle age or the young age group. So we can easily administer the steroids, but the real benefits of the steroids are again questionable mark, as many few papers has to come on the real role of the steroids, and then only we can use it vastly to any other patients. But as far as the risk is concerned, we should assess the patient clinically. We should evaluate the comorbidities of the patient, the risk factors of the patient in terms of later on in, complications of steroids like infections or having the other reactions, and depending on that we can administer steroids easily. That is not an issue.
Right, right. So I completely agree that the role of steroids is of questionable benefits, but at the same time, there are different surgeons who either believe that the steroids does help in their practice, or there is many a times a fear of litigation that if you don't give a steroid, patient lands up in court for an cord injury, and later on tries to pursue that the steroid was not given and that is the cause for his deficit. So there is always this fear. But then if you want to quote the literature in any standing, I would say that this is what is being recommended by AANS, that is an American Academy of Neurosurgeons. They usually don't recommend. Rather, administration of methylprednisolone for the treatment of acute spinal cord injury is not recommended. And in fact, they have reversed the previous opinion in 2002. And to date, the FDA has not endorsed the MPSS for this indication. So we have the different papers available. So the most famous being by the Bracken et al., the 3 NASIS studies which were there, and some were actually the prospective randomized control trials where the use of steroids in acute spinal cord injury patients were used. And later on with the different coming papers, they have kind of negated or strongly criticized this NASIS trial design, analysis, and reporting. if you see the questionnaire survey of spine surgeon on the use of methylprednisolone for acute spinal cord injury, this is a paper in 2006, and there is a vast variation in the usage. There is no fixed dosing being used. No particular surgeon is using for all these cases. So as Dr. Vishal said, it is used from case to case basis, and the majority of the responding surgeon using the steroid protocol as high as 90%. Only 24% use the steroid protocol due to belief in improved clinical outcomes, and most of them use the protocol just because they had a fear of litigation. So that was an important thing. The other neuroprotective agents which are actually in the book, they have been extensively studied in the last couple of decades, are the erythropoietin, the vitamin D, the relusols, the choline stimulating factor. But yes, they are still in their infancy. The long-standing case trials and the randomized controlled trials are still being, there are a few being done in India also, but a long-term and a longer series trials are still awaited. So that is when you talk about the neuroprotection by the chemotherapy agents. As far as surgery is concerned, so as a surgeon, as a spine surgeon, we want to avoid secondary injury. So Dr. Vishal, again, I want to take your opinion on this. So as a surgeon, when a patient has spinal cord injury with a spinal fracture comes to you, what is your goal in surgical management? How do you want to proceed when you talk about the management of the surgical part of the management?
Yeah, in this case, definitely the ASIA score for the neurodeficit really going to help us, like whether the injury is complete one or incomplete one. Incomplete one, in incomplete injury, yes, there is a definitely role of surgical management. If the MRI or the other evaluation suggests that there is a retropulsion of the bony fragments, which are actually compromising the spinal cord in the canal, or any free-lying bony fragments in the canal, which needs to be so that the canal or the cord needs to be completely, properly decompressed, and the bones or the vertebral column should be stabilized. So after a proper evaluation, if we find instability, we have to judge whether the fracture is, which column is compromised more, or all the three columns are gone, and is there any free lying fragment in the canal, or retropulse bony fragments which are actually compressing the spinal cord. So after this assessment, we need to go ahead with the surgery. But surgery, the role of surgery mainly in many patients remain for the ambulation of the patients, because we cannot guarantee even after the surgery the patient is going to benefit in terms of the neuro recovery. But even if he doesn't recover or partially recovers, his ambulation has to be properly done. We can go ahead with the as early rehabilitation as possible after stabilizing the spinal cord or the vertebral column, in terms of like log rolling, sitting the patients, at least standing, or if there is an incomplete neurodeficit, we can just making him stand with the help of the walker or with the help of the supports. So this kind of rehabilitation program can be made easier as early as possible if we go ahead with the surgical intervention in cases of instability fractures. Or definitely these are the factors which has to be ruled out.
Absolutely. So I completely agree that yes, the patient invariably in a spinal cord injury patients with a deficit requires a surgery. The goal of the surgery might vary. If the patient has an incomplete cord injury, something like an ASIA D or an ASIA C, where you are expecting a better recovery compared to an ASIA A patient. That time you want to operate the patient as early as possible, stabilize the spine, give the best chance possible to the patient to recover, vis-a-vis a dense paraplegic patient where the surgery will be more of an early surgery for mobilizing the patient, where you can get the patient out of the bed as early as possible, which will help him mentally as well as helping get out or prevent the early complications. And the early complications can be very devastating. Something like a patient can land up in DVT to a pulmonary embolism, patient can have bed sores, pneumonias, UTIs. So you want to prevent these early complications. So stabilize or decompress and mobilize the patient early is as a spine surgeon want to do in most of your cases. Along with that, whenever you talk about DVT, which is a common problem, whenever you talk about a spinal cord injury patient where there is not much mobility in both the lower limbs, there you want to prevent the DVT. You can do it by the physical something like a graduated stocking or compression bandage to be applied. Early reinstate if the patient is having dense paraplegia, then you start mobilization in terms of passive exercises. Also, you start sometime a chemotherapeutic agent, something like a Clexin, to be on a prophylactic dose, and discharge the patient on Xarelto, which is a rivaroxaban, where giving or taking the tablet at the home or away from the hospital is very feasible. So you want to treat the or prevent the early complications, and most of the time surgery is the answer. So when you talk about the prognosis, so prognosis is something as a patient or a patient's relative, they will always uh, wander around you telling what is the prognosis of the patient. Will my patient benefit out of your surgery? I'm ready to take the patient or allow you to put a knife on my patient, but is it going to benefit them? And what kind of benefit we are expecting? So when you talk about this prognosis, there is always an upper hand whenever the patient is having an incomplete cord injury vis-a-vis a patient having a complete cord injury. So incomplete cord injury usually have a beneficial outcome compared to a complete cord injury. This is a very important slide. When you talk about a spinal cord injury patients, this is an important when you take the decision of surgery, not only at the time of surgery, you want to brief the patient what happens after the surgery. You want to brief the patient how the patient is going to benefit out of the surgery, what are the risks involved. If at all the patient undergoes surgery, how are you expecting the outcome? Is your patient going to walk? Yes, then when is going to walk? So when you talk about this consulting, probably it's a crucial most role. You explain the patient what all options the patients are having, how is patient going to improve over the next few months and years, what are the different strategies are required after your surgery. So it's not the surgery will solve all the answers. Probably surgery will solve less than 50% of your answers, and more than 50% of your answers are hidden in rehabilitation. So you have to brief them everything beforehand. Many times the patients whoever are coming from remote areas, they are having high expectations whenever they land up the patient to a surgery center where they are expecting that the best surgery will be done to the patient and my patient will be probably walking from the hospital to their house. So, Dr. Vishal, how do you deal with this? Whenever the patient, especially you have two scenarios. One, where the patient is having incomplete paraplegia, say Asia C or Asia D. And the second, when the patient is having absolutely zero power with bowel and bladder involvement. Do you brief them differently? Do you always take a detailed consent explaining them everything? Or you want to be very cautious in using those words? Because many times what happens is your words are what the patient and patient relatives are dependent upon. So if you try to tell them all negative, probably they get depressed easily. They won't treat the patient much in the same zeal if they would have expected probably some beneficial answers from you. How do you manage both the patients?
Yeah, right. Definitely. Actually, consent or the proper patient counseling is too much crucial part whenever we perform the surgery on the patient, especially the spinal surgery. We should counsel the patient properly regarding in terms of how much neurological recovery he is going to get after the surgery and what are the actual benefits the patient is going to get after the surgery. Because once you touch the patient or once you move the patient in the operation theater, he's always in the brief thought that after the surgery or after a few days after the operation he's going to walk irrespective of the neurodeficit. So these misbeliefs of the patient has to be properly counseled. The surgery is not for neurological recovery. The neurological recovery is going to take its natural own path, and there are multiple variables which actually aids in neurological recovery. And there are, as you earlier said also, there are multiple factors actually which aid in the proper good prognosis early, or which are the factors which leads to the bad prognostic factors. So this has to be properly told to the patient, and patients and his relatives are properly counseled about this surgery. What we can do is in terms of complete and incomplete neurological deficit, we can at least counsel the patient regarding whatever the damage has occurred is occurred, but the secondary damage, because of patient is already having the incomplete neurodeficit. So if there are, as I said, if because of the instability or retropulse fragment, he should not get any secondary insult and should not deteriorate his power more. So at least to prevent the much more deterioration, or to prevent the deterioration to the complete neurological deficit, we can go ahead with the surgery. But whatever the loss has occurred, we are not going to give the guarantee for the recovery of the loss, and that is going to take its natural own way.
Right, right. So, as rightly said by Dr. Vishal, consenting is the most important thing whenever you are managing spinal cord injury, not only to brief the patient and relatives about the surgery and the surgery related risk, but also the pathway ahead, what we are going to achieve in next few months and year. So, here is an history of 44-year-old male with a history of fall from height, with a severe neck pain and neck stiffness, with no loss of consciousness, vomiting or ENT, played with complete power loss in the bilateral lower limb and some power loss in the upper limb. So, Dr. Vishal, if you have to manage this patient, many a time the patient is having a poor breath sounds, or many a times the patient is having chest injury along with the cervical spine injury with a pneumohemothorax. So, do you want to optimize the patient and take him for the surgery, or since the patient is having quadriplegia, you would go ahead and operate the patient immediately?
No, actually, that is a good question, because everyone thinks like whenever there is a spinal cord injury or spine fractures, and after that the patient is having either the complete or incomplete neurological deficit, it is a emergency and we should go ahead directly with the surgery. But it is not a situation. As we know, in orthopedics also, there are multiple fractures, extremity fractures, which are considered to be the emergency. But at least before going to the operating room, we are going to evaluate the patient's clinical conditions. We are going to evaluate the patient neurologically. So clinically, how much deterioration, neurological deterioration the patient is having, whether it is a complete one or incomplete neurodeficit, what is the status of his bowel and bladder. Along with that, any limb injuries, any vitals organ injuries like chest injuries, intra-abdominal injuries. So ATLS protocols has to be properly followed up after patient's clinical evaluation and after radiological evaluation in terms of X-rays, CT scan, and the MRI. If that particular thing, MRI evaluation, if that particular investigations is going to show us there is an unstable vertebral fracture which is going to damage the cord more if you not fix it properly as early. So these are the conditions where, these are the only conditions where we have to be in a hurry of fixing the spinal fractures. But it is not like to do the surgery in the midnight and all. At least for any patients, we give some time for the patients just to stabilize him hemodynamically, just give some time for the patients to recover from the other injuries. And after taking the proper fitness or proper evaluation, and after preparing our operating room or operating or with having the proper adequate equipments, then only we are going to take the patients in the operation theater. So doing the surgery in the midnight is not definitely advisable, but it has to be done in cases of incomplete neurological deficit as early as possible, so that you can do it in the early morning also, after having the complete proper evaluation of the patients.
Right, right. So, very important facts being told here is that you don't hurry into the cervical spine or any injury for spinal cord injury per se. You will operate the patient, but you want to stabilize the patient first. You cannot take the risk where the life will take precedence over the limbs. And you want to first stabilize the patient's chest. You want to see whether the patient is having spinal shock, along with the patient is having any cardiogenic or a hypovolemic shock. You want to first correct that and not take the patient just to the OR just because the patient is having. Many times you get a scenario that the patient's breath count is not good. Patient is having an ascending cord edema in the cervical spine. You have immobilize the patient on a cervical collar. That is the time you wait, you take a physician opinion, you take your anesthetist, see whether they are okay taking the patient. Many times they say You first optimize the patient for the next 24-48 hours, see whether his breathing pattern improves, and then take the patient. So here I want to take opinion of Dr. Dr. Radha, so many times you see that the patient is being delayed, especially if the patient is having a ascending cord edema in the higher cervical injury, and patient is delayed for sometimes 24 to 72 hours. So is there any role of for rehab or the physiotherapy management when you talk about the patient, when the patient has not undergone the surgery and still is awaiting the surgery, and you have 24 to sometimes 72 hours with you and managing the patient? What differently you do with the patient?
Uh, so it mostly depends upon the extent of the injury, level of the injury, and the type of injury. And especially during this crucial period, it is almost the only maintenance. There is no restoration of function on which we work. It's the maintenance of the body. That is what we work during this phase, and that too in consensus with the surgeon. Because why the surgery is being getting delayed, that is one of the reason that we need to find out. And what is the level and the extent of injury, what can be done, what movements are allowed for the patient to be done and what not, is of utmost importance. Because trying to do something and harming is not the right thing. So with consensus of the surgeon, the thing is managed, and especially this is the time where only maintenance is focused, nothing else than maintenance, not towards the restoration unless and until it's advised by the surgeon.
Right, right. So, very important things have been said here, that you still maintain the patient. You cannot restore the function completely by doing a physiotherapy in those times, but you should not leave the patient then and there. You take care of the DVT prophylaxis being ordered. You can apply some DVT pumps if possible. Do some passive mobilization around the ankles or hip,
Yeah.
knee, depending upon where exactly the patient is having injury. So in this case, it was C6 or C7 traumatic lysis, and you can see an axial cuts where there is a severe cord compression with cord edema. There was posteriorly lamina which was also fractured, and the sagittal section suggesting a bifacetal dislocation. So we had option of anterior, posterior stage simultaneous, or just do an anterior surgery. In this case, we had offered the patient only anterior surgery. We got in a good cage with an anchored cage, and later on the patient was actually having dense paraplegia, so we there was not much improvement or functional improvement in power or sensation in the patient, but the patient was later on shifted to the rehab period. So this was a post-op CT showing a good fusion mass. So with this, I would like to go to the second very important part, is the rehabilitation part, where there are phases of treatment, where an acute and subacute phase deals with whenever the patient is having a neuro recovery, and the chronic phase whenever there is a plateau of the neuro recovery. And the very important sayings and the literature has been given by these two individuals. One is Donald Munro from USA, and Ludwig Gutmann, who is actually from UK. Those were very pioneer in starting the rehab part for the spinal cord injury patients. With this intro in mind, I would like to take here Dr. Sonal Shah, and I want her to continue the next part of the session today, that is the rehabilitation part of the spinal cord injury patients. I feel as a surgeon, we always treat the 40% or the 30% of the treatment of the spinal cord injury patient, and the major bulk is usually taken, and probably for a longer time, by the neurophysiotherapist. And we have very dynamic and very, you can say, a hardworking neurophysiotherapist with us, Dr. Sonal Shah. So from here on, Dr. Sonal Shah, the entire stage is yours. You can go ahead with your presentation. Thank you all for patient listening.
Thank you so much, sir, for the introduction. So, as sir said, my name is Dr. Sonal Shah. I'm a neurophysiotherapist currently practicing at Sancheti Hospital. I've been practicing here since more than a year now. So, as sir mentioned earlier, to the patient, the ultimate outcome post the surgery is what outcome do I get of it? How much can I move? How much can I participate in the society post the surgery is done, post the medical stabilization is done? So that's wherein the rehabilitation part sets in. So this is the topic for today, that is spinal cord injury rehabilitation. So with this, in the rehabilitation part, we'll be covering the acute care interventions that we looked at when the patient is in the hospital, the active rehabilitation that we do to make the patient participate in the community, what all recent advances have come in the physiotherapy, what all neurotechnologies have been used, and what is the future scope of physiotherapy in spinal cord injuries. So starting with the acute care. So the acute care or rehabilitation that we start can be started as soon as the medical stabilization of the patient is done. So once, though maybe the patient is managed conservatively or surgically, once the fracture site or the cord is stabilized and the other vitals have been stabilized, we could start with the rehabilitation protocols. So in the acute care, basically we as physiotherapists or the rehabilitation team will look at the major goal of preventing any other neurological damage. As Sir said, prevention is the best cure. At this stage, we will be preventing any other neurological damage. At the same time, optimizing the recovery of already present muscles that we have, depending upon the level of the injury or if the injury is complete or incomplete injury. The other important factor that we look at during the acute care management is the respiratory management. So when the patient is brought to us, it is not usually only with any spinal like vertebral fractures or anything. We obviously come into account with other respiratory complications. Some patients come up with some rib fractures. So all that has to be managed. So basically, according to physiotherapy, what all techniques we would apply here is we would allow diaphragmatic breathing. So facilitation, there's a technique called diaphragmatic facilitation wherein the physiotherapist applies direct pressure at the level of the diaphragm when the patient inspirates, which is facilitating if the muscles are not acting neurologically because of the level of a higher injury level. If the muscles are not activating, we facilitate those muscles. And during expiration, a sudden thrust is applied so that the air is blown out. So these techniques are called the diaphragmatic facilitation techniques. Other adaptive equipments that we could be using are like the abdominal corset can be given. So patients who have protruding bellies. So in case of those patients, the diaphragm is at a mechanical disadvantage. By applying the corset to the abdominal level, you will be maintaining the viscera and at the same time providing a mechanical advantage to the diaphragm, which applies a negative pressure that is required to hasten the breathing. Because at such times, when in the acute care, positioning is usually very, you cannot give them prone positions to maintain the fracture side and all. So at least these basic adaptive equipments are used at such times to facilitate breathing techniques. At the same time, because the breathing is not happening in an adequate way, there's a lot of accumulation of the secretions which cannot be expectorated. So at those times, we use various techniques like the assisted cupping and the huffing techniques are taught to the patients. Or when there is the lung volumes are at a disadvantage. So those techniques can be taught, like the glossopharyngeal breathing, wherein it is a technique where you assist the patient to breathe so that the chest expands. So the patient is basically asked to gulp a bolus of air into the mouth repetitively so that the expansion of the chest improves. The major and the most benefiting factor in the spinal cord injury, other than other neurological injuries, is the cognition level is not impaired. The injury is at the lower level. So we can use this at the maximum, talk to them and facilitate more and more of rehab and get the utmost participation from them. The other acute care management that we look at is the prevention of direct complications. So prevention of direct complications at the acute stage when the patient is in a similar position for long duration, and there can be, so at that time there could be a lot of complications like bed sore. So for bed sore management, basically positioning is very important. So at that same time, positioning has to be done in a way where the spinal components are not hasted or any difficulty or any twist at the spinal level are not provided. So at that time, you usually provide patient positioning by providing log rolling. Also, the caretaker should be taken into confidence at such times, and the techniques are taught to these caretakers, wherein continuous palpation of the skin, observation of the skin for any damage, any breakage, any erythema, or any rise in the local temperature at the skin should be reported immediately to prevent the bed sores. The other direct complication because of immobility is contractures. So according to a study that was published in 2019 by Harvey, it was said that at least one muscle in a year will undergo contracture in a patient of in a tetraplegic patient basically. So for these reasons, from the acute care, if we manage on the mobilization part, so that will be very effective. So that in the usual acute care is done with in the supine position. We cannot mobilize the patient at that point. So in the supine position, we usually provide bilateral upper limb and lower limb activities together so that the spine is not twisted. So if you go to do upper limb movement single-handedly, there will be rotations at the spine. So at this point, the patients are asked, or the therapist passively asks the patients to do upper limb bilateral activities. These can be done in various patterns, incorporating the techniques of proprioceptive neuromuscular facilitations and the other techniques. And the last part at this stage is the selective stretching and strengthening that we take into consideration. Now, in spinal cord injury patients, we do not want to maintain all the muscles that are tight to be flexible or all the muscles to be strengthened. Sometimes some tightness is useful and beneficial for some activities. Like for example, for sitting, if there a patient has a DFL tightness, like the lower back is tight, that would be useful in such patients to maintain the sitting balance. So you wouldn't stretch the dorsal lumbar fascia in these patients, but rather we would be stretching hamstrings in a patient with in a tetraplegic patient, so that we maintain that level while sitting. If the hamstrings are too tight, the patient will have sacral sitting and not the actual sitting. And selective strengthening of muscles. So basically in the acute phase, as I mentioned, we could not strengthen all the muscles because it will apply a lot of pressure to the spine. So if we are giving in even in a paraplegic patient, if you ask the patient to do upper limb active movements, those should not be entire range of motion. It should be selective for the activity at that point, and later the active full range strengthening can be started. The other uttermost important part of acute care is the mobilization of the patient. So during the acute care, the patient still has a lot of complications which can proceed in, like the orthostatic hypotension and such cases. So at that time, we want to acclimatize the patient to the various degrees of mobilization. We would not advise to get the patient to standing directly. So at such times, we advise the patients, or we take the patients into standing positions on tilt tables or standards where they're continuously monitored, their vitals are continuously monitored. And in case to prevent orthostatic hypotension in patients with higher level injuries, usually elastic wraps or DVT stockings and all abdominal binders can be applied at the same time while mobilizing the patient, so that the venous cooling is reduced. So this is all about the acute care, the basic acute care that we maintain in the hospital. I would like to ask Dr. Radha if she has any inputs to give in the acute care.
Yeah, as very well covered by you, the acute care management. This is the very crucial period actually. If taken proper care in this period, the rehab can go very high, and the chances of the success of rehab mostly depends on this period. The literature suggests that if this period is neglected, and if the maintenance and prevention of complications are not taken care, especially during this period, and not move towards the restoration phase, then the rehab is so prolonged, and we need to wait. Once the complication sets in, like in bed sore sets in, then we need to wait till that it heals, and then we mobilize the patients, and the whole rehab gets prolonged. So this is the crucial period where we need to really focus, and this is what the research says, and this is what we practice to get the maximum out of our patient. Once maintained in this phase, prevention of all the complications are maintained, and we have started restoration in this phase, the rehab can be very well done with the patients.
Thank you, ma'am. So agreeing totally with whatever she said, the acute phase should be managed carefully to prevent any other complications that would delay the rehab. So now, once this is done, once the acute phase is covered, we move towards the active rehabilitation phase, where we demand most from the patients for their restoration. So basically, in the active rehabilitation phase, from the in-bed transfers to transfers out of the bed to wheelchairs, or their doning and doping of the orthosis that we prescribe, should be taken into consideration. And finally, the participation in the community, the mobility in the community, or the environmental adaptations or the adaptive equipment that we'll be requiring should be covered in the active rehabilitation phase. So starting with the right basics. So once we have got the patient into standing passively, now we want the patient to come out as active as possible. So we start with the mat activities, in bed independence, that is called for mat activities. So first basic activity that we start is the log rolling. So in this, various facilitation techniques can be given for log rolling. The patients can use momentum to change the positions, and even the hip head strategy that the physiotherapists usually use for the transfer of the patient. So this position basically is very important to be learned in the initial phases, as this position change is required to avoid any kind of bed sores. So the pressure relief, it's called a pressure relief position. And secondly, even while dressing, sponging, and all these activities require you to change your position. The entire period, you cannot be lying supine. So that's the reason these positions are required. The positions other than sideline. So once log rolling is done, once you come to sideline, we ask the patient to proceed to prone on elbows. So now when the patient has higher level injuries like cervical injuries, this position becomes of uttermost importance, because it is the position which will directly allow the active facilitation, that is the active strengthening of the head and neck musculatures, which is still in position. This can be done with the orthosis on or with. If it is for 6 weeks, we advise it. After that, once the stabilization is completely done, the X-ray radiologically, clearance is got from the surgeon, you can take it without the orthosis, and it will add to active facilitation of the head and neck joint. This position even will provide you active facilitation, that is the co-contraction of the glenohumeral joint, and the scapular stabilizers are activated, which will be required in erect sitting later. Because what is the problem with the higher cervical injury patients is while sitting, they usually attain sacral sitting. They won't be able to attain the erect sitting like the other paraplegic patients or the normal people. So for this reason, they need to maintain the head and neck out of the gravity in forward posture to maintain the sitting. So this strength should be adequate in the later stages. The other position after prone on elbows that we go to is the prone on hands. So this position will be very difficult for the tetraplegics to assume basically, but for the paraplegics, this position is of uttermost importance, because it leads the activation or the facilitation of the hip extensors, which is later utilized in the later part of rehab for the ambulation. So during that phase, this ambulation becomes very important. I'm very sorry. Extremely sorry for that. And the next is, once the prone this thing is achieved, prone stabilization is achieved, the patient goes to supine on elbows. So this is the starting position for sitting. Once the patient is in supine on elbows, you can provide for higher level injury patients ropes or pulleys to get them back up and to get them to sitting in log sitting or normal sitting. Once we get the patients in sitting, we can start balance training in sitting. That is, so I have a short video where we train the latissimus dorsi muscle. So if in case the blocks are placed a little more posterior to what it is in this video, you will get a direct activation. So basically, this is a patient of T8 level incomplete injury, wherein we are trying to maintain his sitting balance and activate his latissimus dorsi. The other patient on your right is a patient of T12 incomplete level injury who has good static sitting balance, and herein we are trying to train for his dynamic balance. So we have made him sit on a boso ball that we call, which is an unstable surface, and giving minimal support posteriorly. We ask him to do task-oriented activities with his bilateral upper limb, which provides him perturbation on an unstable surface, therefore activating the pelvis and the abdominal musculatures to maintain the dynamic sitting balance that he will require to reach out. Next, even proven is aquatic therapy. So according to a lot of literature, aquatic therapy helps even while assisting the initial movement in the acute phase and resisting movement, therefore increasing strength. So here we have tried to take the patient in sitting position who is on a stable surface, but the movement of the water is providing him perturbations, and he is supposed to maintain his balance and at the same time do some upper limb activities. Dr. Radha, do you have any inputs on aquatic therapy that we used for our spinal cord injury patients?
Yeah, as the literature suggests that aquatic therapy is really very helpful, and the main thing that happens is the buoyancy effect. And when one is immersed in the water, when the body goes, its weight reduces. And the same water can be used for assistance as well as resistance training for the patient. So the role is really very important with respect to use of aquatic therapy in spinal cord injury patients. And even it is very well proven in other neurological conditions also.
Okay. So according to literature, basically, there was an article that I had read recently. Systematic review was published around 2016 that suggested that as level 1B evidence to promote aquatic therapy for spinal cord injury patients. The only efficacy is you cannot use them in early stages because the patients do have respiratory complications then. So at that time you are supposed to avoid, but other than that, aquatic therapy has shown to have very wonderful effects. So proceeding to, once the patient has come to sitting, we want the patient to be mobile enough to come to various positions where he can shift. We get the patients to kneeling and other kinds of standing and use of other orthoses. So while selectively strengthening patients, so this is a patient that I'm going to show you who is a T12 level injury 1 year back, incomplete, but currently is strengthening his quadriceps muscle at home with his wheelchair by doing kneel walking. So basically herein he stabilizes his back, maintains it erect, and then uses only isolated quadriceps to move forward. Once we get our patients to sitting, we want them to learn transfer activities independently or with minimal support of the therapist or the caregivers to lessen the burden that the caregivers have. So while transfer training, we ask the patients, if it is a lower level injury, patients to take up the entire load on the hands so as to activating your serratus and your latissimus dorsi and then shifting to the wheelchair as seen in this video. The patient entirely takes the weight on his hands. The wheelchair, of course, is placed diagonally to the bed or to the moving device. The patients can even be taught to transfer from the floor to the wheelchair or from wheelchair to the floor or from one bed to the other. And there are even other adaptive equipments that are available for higher level injury patients, that are harnesses or different other equipments that are available to transfer the patient who cannot lift themselves or cannot take the weight on their hands. So once the transferring activities have been taught, we proceed to gait training. So this is the most important question that our patients keep asking us, that will we be able to walk? If yes, what will be the quality of the gait that we will have? How much distance will we be able to walk? Will we be able to walk indoors or outdoors? So they have multiple questions. So in this case, how to tackle these questions or how to give them the accurate answers should be, I would like to go to the expert for it. And ma'am, what do you say from your experience? How do we tackle these questions in our daily?
As very well said by Pramod Bellari sir also and Vishal sir also, that this is the most important question which the patients ask, even the surgeons as well as the therapist. What is the level of recovery, what they expect? I mean, after the surgery, will my patient be able to walk? And the same question comes to us also. So again, here the thing is very clear that it again depends upon the level of injury. As explained by Pramod sir, that we have level of injury, we have quadriplegics, we have paraplegics, we have tetraplegics things. So it depends upon the level of injury, complete, incomplete है, क्या type का injury है, and accordingly we can make our patient answer them that what will be they wheelchair bound throughout the life, or they will be walking with the help of orthosis right from pelvic support HKFO or AFO only, and with the help of walker or elbow crutches. usually incomplete and quada equina people, they walk with AFOs and elbow crutches. They are able to manage the things. And with quadris, again, it depends what is the level. It is T8, T10 hai, yeah, it's higher cervical. It's if it is higher cervical or the cervical, it is more or less they are the wheelchair bound people. Again, we have options there. Again, it will wheelchair, which wheelchair to be used for the patient will again depend upon the level of injury. So it's very clear and simple that we need to make our patient aware that what is his condition, what is his level of injury, and what maximally he can expect or what maximally he can achieve. Because giving a false thing to the patient is also unethical. So we should be very well clear with our patients that this is your level of injury, this is what it can be expected. And mainly with few patients, we can even give examples or show a video of the other patients who are doing well. So they get motivated and they know, ki, yeah, I can also achieve this level, and they work towards it.
Correct. So as rightfully mentioned, based on the level of injury, the patients are supposed to be explained that the functional capacity with using your adaptive equipments would be this much. So for that same, agreeing to that, I would like to show you two videos. So on your left is a video of a patient who is a quadriplegic who we have mobilized using an HKFO, a gutter walker, and still we needed a thoracic binder to maintain his trunk. So we started this. This is the very acute stage. It is the first month that this video was recorded. So it is almost facilitating the movement rather than the patient actively participating in the movement. So we are asking the patient to actively at least shift weight from one leg to the other so that the bystander or the caregiver can shift the other leg. So this was about the quadriplegic patient. And the other paraplegic patient that we are seeing, in them we would not require a higher level orthosis who can maintain their trunk balance. So for them, so this patient is again like the previous video, he's the same patient. He's a T8 level injury patient. We used static AFOs with long knee braces and elbow crutches for him. So initially we started his training similarly on HKFOs. Once he started gaining strength with the therapy, we narrowed it down to AFOs and long knee braces, and now got into elbow crutches, where he is doing overground training, like on the ground training in the rehabilitation department as well as in the community. So with gait training, I would like to emphasize that gait training in the department is feasible, but community adaptation of gait training, and that becomes very important because eventually the patient has to move out of this, face the barriers that are present outside, and walk in his community. So community training becomes very important. And again, to add to what Dr. Radha said, there's a prediction gait model that was given by Lancet in 2012, published in Lancet. The 5 variables that are very essential for gait training or the quality of gait that the patients will achieve is in 1 year. What is the age, like at the time of injury, what is the age of the patient? What is the quadriceps strength at 1 year? The gastrocnemius strength at 1 year? Light touch sensation present at L3, which is roughly around the knee joint, and at S1. So these basic factors will help us determine that how much recovery the patient will have eventually, or how much can we narrow down the adaptive equipment from HKFOs to KFOs to AFOs, or functionally walking only with splint will be feasible for a patient. So this prediction model is usually taken into consideration at 1 year. Now, like I mentioned, that overground training, that is activity-based training, is very essential. That is stated according to the literature of a lot of people around the country and outside the country. But at the same time, the literature states that repetition is very important. You cannot have enough repetition in the rehabilitation department. So basically, the patients come for 2 to 3 hours, 5 days a week. So in that time, the repetitions that are required for the rehabilitation are not achieved. So according to a study again published by Merrill, stated that more than 1,000 repetitions per week is essential to gain the amount of recovery that you, for your minimal goals or gait training in a year. So for that purposes, we use adaptive other technologies like your treadmill, body weight supported treadmill training, or robotic training. So I have added this video of a patient in his house when he has bought treadmill for his rehab because he could not be here as he stays far. So Basically, even this patient, as we started with HK force, narrowed it down to A force and long knee braces, is doing his ambulation or training on the treadmill. And the next important factor that I mentioned was community training. The even surfaces in the rehabilitation department become easier for the patients to gain control, or they get acquainted to the environment after the long therapy that they've been. Mostly, usually the patients that come to us stay with us for at least a year or more. So they get adapted to the environment. They know where the obstacle is. They know what distance it is, what walking speed will be required. So at the same time, community training is very essential in such patients. And also in community, we see a lot of ramps, slopes that the patients need to be acquainted to. So initially we started the rehab of this patient on the ramp that is present outside the hospital at the entrance, with support, with the braces on, with the elbow crutches as well. So this is a video that is taken 2 weeks post we started it, and the confidence that the patient had post 2 weeks was much better than on day one. The patient was able to at least, lower, shift his weight, come out and transfer the weight. So those are the techniques that need to be learned with physiotherapy, because the lower limbs or the other muscles are not activating. What techniques of the upper body or the other muscles can be used, selective extending can be done to transfer the weight is very essential and to be learned. So this is the active rehabilitation part. From here, I would like to take it into recent advances that physiotherapy has come across. So as I mentioned earlier, that now we focus on the repetitions. For the activation of the central pattern generators, the repetitions, that is more than 1,000 repetitions, is usually essential. Many equipments have come forward, like the robotic treatments and the bodyweight supported treadmill training. So, Radha ma'am, what is your view on these treatments that have come forward? Do you feel that this is somewhere taking away the manual job that we have?
No, I would say, as with respect to the gait, we have options like ground level walking, walking on treadmill with body weight support, treadmill training. Then we have aquatic. Then now we have this robotic assisted gait training. And the more recent coming is your epidural electrical stimulation for the gait training thing. So there are many variations, but everything has its own pros and cons. And everything is in, see, ground level walking is already, which is the routine thing, which is the conventional thing, which we are already working on from decades. Ground level walking. Then came in the body weight support treadmill training was the thing. The advantage with body weight support treadmill training was, or is, I would say, is it can be started early in the rehab. As the body is supported, it can be started very early. It gives confidence to the patient. Once a patient walks, he feels that, oh, today is the first day I had walked and I would be able to walk. So the confidence level of the patient increases with body weight support, and it mimics the normal gait. So these are the advantage with the body weight support training. Even the literature suggests that it helps reduce your muscle atrophy as well as maintain your bone density also. So that are the advantages with body weight support training. But again, the meta-analysis shows that when compared with the ground level walking and body weight support treadmill training, they didn't find that much difference with respect to both of them. But there are not many factors when you choose which approach to be used for the patient, right from feasibility and the patient's the equipment need to be available at the hospital. Is it affordable by the patient? And in long run, how much it will take the patient to? So these are all the things that you need to consider. Even the same is happening with the robot assisted training. As your question was that will it take the manual job? No, it will not, definitely. The body weight that we take of the patient, or it will be more better for the occupational hazards for the therapist will be avoided with your robotic assisted training, but it is not going to take the job totally. Because when we work on this robot assisted training thing also, we need to fix the angles. Hip में कितनी movement चाहिए, knee में कितनी movement चाहिए, ankle में क्या चाहिए, कितना percentage of body weight of the patient will be taken by the body harness and by the patient. This all need to be clinically judged, and that can be only judged by the therapist. So it's not going to take, definitely it is going to make our job easy, but at the same time we need to think about the cost effectiveness and the availability of the machinery, because it is totally dependent on the machine. So this is the thing which can be only done in the setup. Patients, they cannot do it at their home, or the patients who are requiring long term of therapy. So again, there is also ambiguity with the use of robotic assisted training. It is very recent, and there are many articles and many literature in the paper getting published with respect to robot assisted training. So but there are very less papers with per se in the Indian scenario.
Correct. So I totally agree with whatever you said, because what we see is, so physiologically, the main goal of the physiotherapy or rehabilitation is to mimic the gait that we normally have. And if we look at the physiology that we follow, that the central pattern generators follow, that the half life, the pattern that is generated during gait is when half the nucleus is activated, the half is inactive, and the other half activates over to generate the gait. So that is usually not provided by the machines. Totally agreed with what she said. And just for the viewers, I would like to introduce robotic assisted training a bit. So robotics is available in two types, that is the exoskeletal robot and the end effector robots. Exoskeletal robots is basically something like your orthosis that we provide to the patients. Just we can fix the angles to mimic a more normal like gait, but not normal gait. But it won't activate the physiologically the half nucleus that we say to activate the CPGs in an exact manner. And the other is the end effector robots, which is usually used at the distal joints, which provides your grips and your grasp and all those activities, but they compromise a lot on the proximal joints. And the other was the body weight supported treadmill training. So basically, the patient is attached to a harness and is made to walk passively for developing again a near normal like gait pattern. So as ma'am mentioned, the systematic review that was published in 2017 by Merrolls, it compared the robotic assisted training and body weight supported treadmill training on overground training. So how is it different? How is it superior? Or how is it same? So basically what they observed was there was no significant difference in the walking speed and the distance that was performed, but it definitely provides assistance and increases the number of repetitions that we require for rehabilitation. So it can be used as a conjunct, but it cannot replace physiotherapy or the normal overground training that we are doing today. And basically other thing that has come in the literature is the activity based intervention. When you want the patient to walk on the ground, that activity should be done more with more repetition than the repetitions that are done with the robot or on the treadmill. So basically that is very important. So activity based training is very important again. But yes, body weight supported treadmill training and robots can be used as a conjunct for helping or assisting the number of repetitions that are required to achieve our goals. So this was about the recent advances that have come in the following years. Now moving on to the future scope. So in the past few years, in a couple of years, it is seen that the electrical stimulation that was provided directly dorsally on the spine, which is an invasive procedure, helps in a non-patterned movement in the lower limbs, which has effectively actually shown improvements in the lower limbs. The only dirt in the literature with this is that it is not, the FDA has not given approval to this yet because it is done on very few patients. The other drawbacks are it is a continuous current and they are non-patterned pulses. So we do not know what part is exactly activating. We have gotten to know that there is some activation and some movement with a direct stimulation, and this is a direct current that we usually use for chronic pain management. It is not tailor-made for patients with spinal cord injuries. So if there are any other hazards which is not known as of now, and there are varied doses. So this article, they had shown 3 studies which range with varied doses from 25 to 60 hertz and 5 to 9 volts. So we need to come up with a more tailor-made dose that can be provided with the training of gait during such kinds to activate the more likely central pattern generators while gait training. So that is where the future scope goes. With that, I come to the recommendations with what physiotherapy gives is start early. With early, I mean as soon as the medical stabilization is done, the patient is stable, the vitals are stable, the rehab has to be started inpatient. Do not wait, because the disuse, atrophy, or deconditioning of the patients is way more worsening later in the scenario, and the rehab takes double the time or even more to come up with the same that the patient might have recovered initially. Focus on the repetitions right from the start, right from the acute stage. When you start with active strengthening of the available musculatures, focus on the repetitions. Education of the family members and prevent direct complications. So the family members are supposed to be educated about the bed sores, the other disuse, atrophy, deconditioning that is going to take place, or other urinary tract infections, or the autonomic dysreflexia. All these have to be explained to the patients right from the start and the caretakers, so that they can be taken into consideration, or at most acknowledged if anything per se happens. And tailor-made interventions at home is the most essential things. So as we know, spinal cord injury rehabilitation is a very long process. It's actually a lifelong process, cannot be stopped. So intervention should be tailor-made for the caretakers to take at home. That is the reason I specifically included articles of patients that were taken, videos of patients that were done at home, so that the rehabilitation at home continues. And when they come up, we can progress the patient from where we have left them at the last time. And other environmental and home adaptations for grills and bars should be very essential for the patients. So that's it. Thank you so much. Are there
Thank you,
any
Dr.
questions?
Sunal. I think it was a. I have a couple of questions.
Sure, sir.
As a spine surgeon, we want to operate, as I said, most of the time we want to operate the patient early, decompress early, stabilize early, and mobilize early. So, as per your protocol, when you would like to mobilize, is it okay for you to mobilize the patient early, or you still want to keep the patient in bed for a couple of weeks? Are there any advantage of mobilizing the patients early vis-a-vis a patient mobilizing after 2 weeks?
So that is a very important question. There is actually a literature based on this, that how early can you mobilize a patient with spinal cord injuries. So basically the only complication with spinal cord injuries is there is a cutoff to the supraspinal pathways. So that leads to a lot of other complications that come into phase, like your orthostatic hypotension and other complications that are needed to be taken into consideration. Once we neutralize, or the surgeon gives a go that this is under control, you monitor the vitals, the mobilization can be started as early as possible.
The second thing I wanted to ask was for now, the second most common complication usually has is the bed sore.
Yes.
So, what specific positioning you advise? Like many times it happens that the most common locations of the bed sores are actually the sacral area of and the hands might be at the olecranon level. But if you mobilize or to make the patient lie down on the lateral side, then you have a GT ulcer which is developing. So, is there any specific thing you tell the patient to lie on the prone position or a supine, or how early or late they need to change their position?
So we take basically
Sonal,
all our patients, we
Sonal,
give 3 advices. That is.
sorry to interrupt, Sonal. Just stop sharing your slide.
Oh, sure. Sorry. Yes. So basically, we take 3 things into consideration right from the acute phase. We tell the patients that they need to do log rolling, that we teach them initially every 2 hours. Then we provide them with pressure relief positions. So even if they're in the wheelchair, they are taught how to shift weight to one side of the body so that they can relieve pressure from one side and again go back to other side. And the third is adaptive equipments that we use to relieve the pressure, like foam rolls are given, cotton pads are put, and basically even the continuous ointments and all that are suggested. So these are the other things that we take into consideration to avoid all these bed sores and other integumentary problems.
Yeah, absolutely. Dr. Vishal, you have any questions to Dr. Sonal or Dr. Radha?
Yeah, actually, they nicely explain what are the roles of early rehab, even before stabilizing the spine, and what are the importances and how to go ahead with the preventing the long-term complications. It is very nicely explained. But
Yeah.
I would like to just ask Dr. Sonal,
Yes, sir.
uh, how early can you go ahead with the mobilization of lower limbs or calf muscles, irrespective of the surgery, to prevent the deep vein thrombosis?
So depending upon the level of the injury, the other part, so basically if it is a higher level cervical injury, leaving the cervical muscles, the lower lip and the lower joints can be mobilized because it won't be harming the cervical as such. So we take into consideration that that part is immobilized, but the rest is mobilized to avoid the deconditioning effects. So if it's a higher level cervical injury, we avoid the scapular stabilization training, the head and neck training that we give, that is essential for sitting later. So that is avoided in the acute phase. Whereas if it is a like lower lumbar injury or thoracic injury, we avoid other pelvic activations or abdominal activations, which will give a lot of pressure to the spine. So once that is stabilized and the radiographic green go is given, like you can now everything is healed and you can go. Basically, this is 6 weeks. We in the hospital follow 6 weeks here, and then we mobilize that joint as well.
So in early phase, do you really rely or give more importance rather than mobilization to the other methods of, like preventing the DVT, like DVT pumps,
Yes.
DVT stockings, and also rely more on those methods than mobilization in early phases?
So mobilization in the early phase, we do focus on it because we want the patient to be acclimatized to the various degrees of orientation. But that in that phase, it is usually more passive like than the active phase. So usually in those phases, the patient is on a tilt table or basically a wheelchair mobilization during those phases. We do not actively want with the orthosis that the patients mobilize themselves. But yeah, avoiding the direct complications in the acute phase is the first goal because prevention is a must at that stage, because if you get a bed sore or if you have other issues, then the rehab is postponed. It takes a lot of while later.
Yeah.
Yeah, absolutely. So I think it was a good session, considering the extensive talk by Dr. Sonal regarding briefing us what exactly goes into the rehabilitation part. Many a times we usually don't visit the rehabilitation center in Sancheti, but now I have got you can say a bird's eye view what happens exactly, and a commendable work being done at the physiotherapy center at Sancheti. So with this, I would conclude the webinar. So extremely thank you for everyone, Dr. Vishal, Dr. Radha, Dr. Sonal for an excellent talk, and to the organizing committee here, Rahul Chaube, Mr. Rahul Chaube, and Dr. Ashok Sham for giving us time, valuable time, and the screen presence to share our work, as well as briefing the entire community about the and sensitizing them about the importance of spinal cord injury and the rehabilitation. Thank you everyone for your valuable time.